I'm Veerle Bergink. I'm director of the Women's Mental Health Center at the Icahn School of Medicine at Mount Sinai, and I am a professor in psychiatry. During this presentation, we're going to discuss how to treat women with severe mental illness during the pregnancy and the postpartum period and prevent relapse. And that is something most psychiatrists find a difficult period, pregnancy and the postpartum period, for patients with bipolar disorder or psychotic disorders, mainly because during pregnancy, of course, you have to think about which medication to use and to balance the risks and the benefits for mother and child. And we know that the postpartum period is an extreme high-risk period for relapse, for getting sick, especially for bipolar patients. Also, a high-risk period for patients with psychosis in history. And we want to make sure that we prevent these episodes. So this session is mainly focused on which medication to use during pregnancy and which medications not can be used, other strategies, and to have a better sense of the absolute risks for certain populations. In terms of treatment for women with bipolar disorder, we, of course, absolutely advise against use of valproate, given that it's highly teratogenic. So no women in their fertile ages should use valproate. Carbamazepine is also teratogenic to a lesser extent, but still that is not recommended. We know that lithium is during the first trimester in higher doses teratogenic, but yet we also know that many women need lithium to maintain mood stability. So for lithium, in most cases, we advise to lower the dose during the first trimester. And what actually to do is dependent for each patient, what their risk profile is. So this is a general recommendation. And during our session, we will also discuss the use of antipsychotics, which are not teratogenic, but also do not have that much efficacy data during the perinatal period. So we would like clinicians to be mindful with polypharmacy or too high doses. And also we know that there are some obstetric risk factors, including weight gain and gestational diabetes. Some of the issues are both overtreatment and undertreatment. So we know that in general, there is a huge increase in society, especially among women, of psychotropic use, whether it's SSRI, antidepressants, benzodiazepines, stimulants. There is just a huge percentage of the population using psychotropic medication, and the indication is not always clear. So when women get pregnant, and most women get pregnant in their life, then many of them are on medication. So then in a way it's already, well, not too late, but in an ideal world, people think about it, prescribing to women in their fertile ages. And we know that many people in the general population can very safely taper the medications we're on. So in that sense, there might be some overtreatment during pregnancy. At the same time, we know that there is undertreatment during pregnancy. So we know that, some women at really high risk or having chronic mental health problems who really need their medication to remain stable, whether that is depression or anxiety or OCD or bipolar disorder, that sometimes other women are not on medication, or their health provider or themselves, they panic when they get pregnant and just stop. Whereas actually they benefit more from continuing this medication during pregnancy because they need it.